I am Dr. Bharat Koyani, MD pathologist residing in Rajkot, Gujarat, India. Today we will discuss a clinical case of myelodisplastic syndrome mimicking megaloblastic anemia. A 70 years old male patient was presented to a physician with the complaints of easy fatigability, pallor, and dyspnea on exertion. He was investigated. His hemoglobin was 6 gram percent, total WBC count was 11,000 per cmm, platelet count was 250,000 per cmm. Peripheral smear examination showed hypersegmented neutrophils and some hypogranular neutrophils. The RBC series showed macroellocyte, anisocoagulocitosis, teardrop cells, and some microspherocytes. The patient's MCV was 102 femtoliter. Now, looking at the age of the patient, anemia, and peripheral blood smear examination, the pathologist gave the provisional diagnosis of megaloblastic anemia with probable iron deficiency. The patient was again investigated for B12, folic acid, and iron profile. All these profiles were normal. Even though they were normal, the patient was treated with B12, folic acid, iron, and pyridoxine. He was also transfused 3 bottles of blood. After 6 months, the same patient came to the same laboratory for CBC and peripheral blood smear examination. The results were almost the same of the previous one. After looking at the age of the patient and refractoriness of the anemia, the pathologist gave the provisional diagnosis of myelodisplastic syndrome. The patient was sent to hematologist where bone marrow aspiration and biopsy was done. The bone marrow sample was also sent for cytogenetics and molecular genetic study. After getting the reports, the hematologist confirmed the diagnosis of myelodisplastic syndrome. Now, what is myelodisplastic syndrome? Myelodysplastic syndrome is a heterogeneous group of disorder characterized by hematopoietic stem cell defect with ineffective hematopoiesis resulting in cytopenia. How to diagnose or how to suspect myelodysplastic syndrome? As a primary care pathologist and physician, if there is any at least one cytopenia which persists for 4 months, and if there is no secondary cause is found out, then we have to suspect myelodysplastic syndrome in an older patient. Age should be more than 50 years. And if it persists for 4 months, the myelodysplastic syndrome should be considered. Then the bone marrow examination for aspiration and biopsies should be carried out. In bone marrow aspiration, we should find out at least 10% of the dysplastic changes in the affected series. Now, when the erythrocytic series is affected, we can find out multiple nuclei in normoblast, budding of the nuclei of the normoblast, and megaloblastoid changes in the normoblast. When granulocytic cytopenia is there and there is a dysplasia of granulocytic series, hypersegmented neutrophils or hyposegmented neutrophils having the pseudopulgar-Pelger-Hewitt anomaly, and hypogranulation is found in granulocytic dysplasia. When there is a megakaryocytic dysplastic changes, the megakaryocyte becomes very small and uninucleate. Sometimes the multiple nuclei are also present in a large megakaryocyte. Now, to diagnose the Myelodysplastic syndrome, the cytogenetic changes are also concerned. When there is a 5q deletion or 7q deletion or monosomy 7 or trisomy 8 or 20q deletion, the diagnosis is suspected, and in classification, if the 5q deletion is there, it is confirmed diagnosis of myelodysplastic syndrome, and that entity is also kept in the recent WHO classification. Second genetic defect is SF3B1 mutation. If this is there, the diagnosis of myelodysplastic syndrome is confirmed. Third genetic defect is biallelic multi-hit TP53 mutations. If this is there, the diagnosis of myelodysplastic syndrome is confirmed. If these three defects are not found out on cytogenetic and molecular genetic studies, and other genetic defects are found out, it will establish the clonal cytopenia or clonal expansion of the hematopoietic cells. And there is no single pathognomonic characteristic to diagnose myelodysplastic syndrome. We have to compile many things, and then we can diagnose myelodysplastic syndrome. As for example, the single most required entity is at least one cytopenia, and at least 10% of the dysplastic changes in the affected series, and presence of molecular defects in the bone marrow aspiration cytology. Now, recently the WHO has put a new classification about the myelodysplastic syndrome, and it is very interesting that it is not a single disease. It is a group of diseases. In certain myelodysplastic syndrome, we do not know the cause, but it is a clinical headache, and we should keep in mind myelodysplastic syndrome when there is persistent cytopenia which have no secondary cause found out. Thank you very much.